For a number of years I worked in London for CRI, and I was responsible for running perfectly good treatment services for people with drug and alcohol problems. And generally speaking, the people who got better were people who had other things around them. They moved on. Perhaps we didn't do much to build other things around them. We put them out into the world, drug and alcohol free, and the people who had stuff around them did well. About 6 years ago I went to the north of England to work, and I visited some places in Merseyside, which I think David is familiar with, that sort of blew my mind and made me feel like an idiot. Because what was happening there was we were running perfectly good treatment services. Again, we had doctors and nurses and governance, and we did everything just so by the Orange Book and so forth. But alongside that, it was very evident that the people who were accessing our services were being treated as an entire human being who had some issues in their life that they wanted to overcome, rather than as a problem with legs. The fact that they had a substance misuse issue was, of course, the acute reason for them to come to us, but actually our service had responded to the whole person. They were looking at the whole thing, and actually, other than those highly regulated, very professionalised interventions, an awful lot of the rest of the stuff that people were doing in some of those services was about, what are you going to do once you stop doing this? And it led me to a comment that one of my friends made. They were talking about recovery not being about the absence of something, it was about the presence of other things. I've been working in this field for 20 years, and I saw this stuff, and I saw a lot of people getting well, being not just drug and alcohol free, but being happy and doing rewarding things. Now, in that part of the country, the workforce is culturally in the place to, of course, still deliver the highly regulated and professional stuff, but also do something that's a bit broader, that's more about, and what happens to you when you don't come to us anymore? And most importantly, you don't want to be coming to us for the rest of your life, do you? The development for me was, that's where I saw it. And I would say that about 5 or 6 years ago is when the stuff that, to be fair to David, has been going on about for a number of years longer than that, started to actually be realised in services. And I find as you come down the country, the recovery ethos is a little stronger in the north. It's there in the Midlands. Have to say that. It's there in the Midlands, and as you get down to London, perhaps the services aren't quite as engaged with it. Part of that might be because people in London and the South East just have more opportunities anyway. Maybe it's not been the rock bottom thing that some of those communities in the northwest of England had. If you only use evidence-based practice, you never have any kind of innovation. There are things where evidence-based practice is incredibly important, and obviously your Orange Book guidelines and all these things around clinical intervention and so forth, they need to be done just so. But if you only do what people have done before, nothing changes. And actually every great advance in humanity is about someone doing something that didn't have an evidence base because they had a hunch. What working with RSA is about is looking at practice-based evidence and seeing if we can prove to people that this is actually a better way of doing things, that's more effective, gets better outcomes, potentially is cheaper as well, which is of course an important thing. Read the paper, see what's there, see if you believe it. I know that it's not been made up, I know that this stuff works, I know that it works in other parts of the country too, and it's important to me that we do have solid evidence. The fact that recovery is both possible and that social networks have a huge part to play in that. I want to be able to prove that to people rather than just say I sincerely believe it, because I do sincerely believe it. And then we come to the challenges. And everybody expects to say the challenge is the dreadful government funding cuts, right? Because obviously it's dreadful and government funding cuts. I like to go strengths-based about this. The cuts are what the cuts are. Would I like to keep the same level of funding? Of course I would, because then I could do more of whatever it was I was going to do. But actually, there's a bit of me that thinks that for the sector, the necessity to look at different ways of doing things might not be all bad. There's a baseline level of funding that I think is required to keep things safe when people are in very acute need. We now have a situation where if we continue to do the same things with less resources, that arithmetic tells you it's going to turn out worse. Right? You don't need to be all that good at sums to work out that the same with less equals worse. I seriously believe that using some of the principles that are in the RSA paper, we can not only not do worse with less, I think it is possible that we can do better. I think that this might be the poke that the sector needs. It's a pretty severe one, and that's the big challenge for me, is that culturally not all of the services across the country are ready to make this shift. I have got some that I'm very happy about where we've been working for years, and culturally they're embedded in their communities, they're using the resources that exist outside of the services. In other places, it is going to be a big shock. The transition from what has been a doing things to people treatment service to the doing things with people recovery service is not one that happens overnight. And I think that if the cuts come too quickly and too strongly, some places will really suffer. It will show that those places that have adopted this approach earlier won't suffer nearly as much, because the resilience of those communities and the abilities of people to support each other, with people like us just providing professional support to recovery communities. It wouldn't be the way I'd want to evidence that it worked by there being disasters anywhere. But I do think that going forward, if things are done sensibly, we can do better with less. I really do. And the challenge is making everybody believe that, and particularly the staff that continue to work in the field.
On that kind of provocative point, we'd like to move over to David Best to talk a little bit about the research landscape in the recovery sphere.
Recovery's been a highly kind of contested term since it started, and I guess one of the mental health definitions of recovery has tended to think of 4 different ways you could conceptualise it. So there's personal recovery, which is subjective experience, clinical recovery, which is the alleviation, amelioration of symptoms, social recovery, which is about how other people see you and how you engage, and functional recovery, which has probably been the most contentious part in the UK, which is about getting on with your life, jobs, work, safe housing, that kind of thing. I think irrespective of where you place your emphasis in that particular model, I think it's important to say that the whole concept of recovery has been fundamentally transformative and challenging and provocative. And I've just made a note of 3 things that I think, and Mark alluded to several of them, that are fundamentally challenging to the field. So the first one is the transition from a pathology model to a strengths-based model. This is not unique to recovery, either addiction or mental health, because it's entirely consistent with a whole field of positive criminology, positive psychology, therapeutic jurisprudence. This is a switch in the way we understand how to make things better, not by making a big list of ailments and then trying to tick them off one by one, because it doesn't work and it's not holistic enough. The second, which is a huge challenge to professionals, is the switch from an expert model to a partnership model, which links to the third, which is the switch from the clinic as the locus of solutions to the community as the locus of solutions. And all of these 3 things are fundamentally challenging. And again, to go back to the mental health field, there's a reason why this is relevant to recovery. And in an overview analysis of what works in recovery interventions, published in the British Journal of Psychiatry in 2011, Leamy and colleagues used an acronym called CHIME. And CHIME represented the key characteristics of effective recovery interventions. What were they? Connectedness, other people, hope, a positive outlook, identity, no addict identity, but a positive identity, meaning, something to do that's purposeful, and empowerment. Those were the core characteristics of what we know is successful. And the journey to recovery is a process, not an event. And we know that in the first year post-detox, the relapse risk is between 50 and 70%. By 5 years, it drops to 15%, at which point it plateaus. Acute services can get you to that clean point. It's recovery services, your family and your community, that see you through that process. And in our own work in recovery capital, we've talked about 3 component parts. Personal capital, which is things like resilience skills, self-esteem, self-efficacy, coping, communication skills. Embedded within social recovery capital, which is all those crucial things around transitioning from networks that support your drinking or drug use to networks that support your sobriety. And by far the largest global addictions outcome study, that's the single biggest predictor of effective recovery, transitioning your networks. In 2008, we published a paper which said the initial ability to stop is about psychological change in events. Sustaining the stopping is about who you know and who you spend time with. So this is crucial. But the third thing, and the thing that I want to add to that discussion, is community recovery capital. Not just about the person or their family, it's about all of you and all of society, because it's about, in that 5-year journey, will people allow you to be reintegrated? Or do they have that attitude that says, well, I know they're in recovery, but I don't really believe that. They're still an addict, really, so not in my university, not in my street, not in my workplace. Because effectively, for us really to make recovery happen, there has to be a social contract and a social justice contract that says we will allow and engage people to change. There's a very famous criminology writer called John Braithwaite who argued societies can be split into two groups. The ones who do disintegrative shaming. When somebody has been excluded, they're not allowed back in. They become marginalised, they become whatever you want to call it, underclass, dispossessed, excluded. Or you can have reintegrative shaming, where you say, when people are excluded, they are supported and helped to effectively reintegrate. And that's not about professionals, and it's not about the person, because they can only go so far if society won't support them. And we hear professionals in the alcohol and drug field bleating endlessly about journalists using language. Well, we just finished a stigma study where what we found was that among trainee professionals, there is still a huge amount of residual stigmatisation, social distancing, exclusion. So we asked all these questions about would you be willing to go out for a meal with somebody? Would you have them look after your children? Would you have them work beside you? And as was found in America, with active addicts, the answer was no. But with recovering addicts and recovering alcoholics, the answer was still only a very partial yes. And if our potential professionals don't believe that people can really recover, how can we expect the general public to? And one of the massive challenges for a recovery movement is to move from a world where recovery is this kind of anonymous, underground, hidden thing, where people feel that to sustain a recovery journey, they either join anonymous fellowships or they move to Devon and start again, to a world where there's genuinely a therapeutic landscape of recovery and a therapeutic belief that people can change and make those sustainable things. Now, that's not a treatment journey. That's about creating visible, positive icons of recovery. In Australia, where I work a couple of months a year, we've just finished a study where we showed a quarter of the alcohol and drug workforce in Victoria have worse psychological health than the average client at intake to treatment. The burnout, secondary stigmatisation and exclusion of our workforce itself is a huge problem. And the notion that recovery only applies to the client is misleading. It applies to the client, it applies to their family, but it applies to an awful lot of workers. And one of the points about that 5-year journey to recovery is it stops being about drugs, alcohol, crime, disease, and becomes about lifelong concerns about giving back, making a contribution. And that should apply to the workforce in our field as much as it applies to the clients. It should apply to academics as much as it applies to clients. And that notion of recovery as holistic means holistic in two senses, not just about the person's own life, but all of us together in a joint endeavour. And that's fundamentally the social enterprise challenge. So I'm going to finish by mentioning two really positive projects that I'm involved in. One is a project called Jobs, Friends and Houses in Blackpool. And Blackpool is a highly deprived area. And in Blackpool, in an attempt to create a therapeutic landscape, people coming out of prison or coming out of detox or rehab are invited to start an apprenticeship to physically build the recovery community, to build recovery housing. They do it in a very high profile, highly visible way. And people are inspired by the idea they're giving back, they're building a recovery community, and they're seen by the community as doing something positive. In the first year of 40 people, there's been one relapse, and there's been no reoffending among the initial cohort of 40. And in our field, that is almost unique. It really is a glass half full, glass half empty question. I've been asked a lot in the year since I came back from Australia, are we doing well or are we not doing well? Well, it seems to me one of the things is there are huge examples of positive practice, hope, innovation, excitement, empowerment, but it's still patchy. And one of the challenges, I think, for all of us is to live our lives in a way that supports and is open to recovery, but also to kind of disseminate and promote innovation and exciting new practice. There is plenty of recovery evidence. It's convincing people who don't want to be convinced that it makes differences not only to a group of people who are excluded, but that the recovery population are a significant bonus and benefit to the communities they live in. And so the idea for supporting recovery is not just to help people get better, it's to make the places we live better places to live.
And we're going to move over to Sunny Dudley now to talk about peer-led approaches and the relationship between peers and commissioners and the rest of the sector.
So back in 2007, I was an active heroin and crack cocaine user. I wanted to change. I decided that on a number of occasions. But this time I really wanted to change. I approached my local treatment provider, who subsequently told me that there was no funding left for me to detox, which is what I wanted to do. And by hook or by crook, I managed to get what I needed from them, which meant that on the 10th of September 2007, I started a community detox. I finished it on the 20th of September 2007. Got married on the 30th of September 2007, which was also my 27th birthday. Flew to Bali, had a wonderful time, instant gratification. I knew straight away that the decision to kind of change was the right thing to do for me and my future prospects. Landed back in the UK, at which point I thought, well, what do I do with myself? I had an overwhelming desire to help other people. And at that point, the kind of word recovery wasn't really heard of. Peer support wasn't really heard of. Luckily for me, there was a new project that had just been commissioned around service user involvement. At which point I went along and I signed up as a volunteer. And that enabled me then to share the message of kind of hope and recovery with lots of different people. I suppose one thing I must say is that there was nobody directing this. There was no person saying to me, well, actually, have you considered going back into education? Have you considered doing, looking at your employment opportunities? At the same time as volunteering for this service user organisation, I got some experience within a treatment provider setting. So I was on the other side of things, carrying out triage assessments, running needle exchange programs, etc. Within 6 months of volunteering, I became a project worker at this service user involvement project. A month after that, the manager left. I applied for that, and I've been managing an organisation called Suit for the past 7 years and 2.5 months. It's taught me an enormous number of things in lots of different ways. This quite, dare I say, tokenistic service user involvement project at that point had a very limited service level agreement. It said things like get involved in interview panels, get service users feedback, which is good and it's important. I'm not saying that it's not. But then it soon became apparent, especially as I became more knowledgeable at a strategic level, that there were lots of things that were being promised and there was lots of agreements that were being made. But because we were working with people on a grassroots level, on the ground, I became increasingly frustrated as to why these things weren't being panned out at ground level, why people weren't experiencing the strategic decisions that were being made. At that point, I thought, well, actually, if people aren't necessarily going to get the help and support that they need from places where they should get it, then why shouldn't we be the people that provide these interventions? As we stand today, we're a very small organisation made up of the equivalent of 3 staff and about 5 volunteers at the moment. And I manage a public health contract, which means that we're contracted the same way as many drug and alcohol treatment services are in this country. We're hosted within an infrastructure organisation, which has got nothing to do with drugs and alcohol. But there's somebody to go to in case, we need to run something by them. Policies, procedures and things like that are in place. I believe what started off has now developed into a way of supporting people that I think there's a lot of lessons to be learned from. One of the things I took for granted in my early recovery was that I had somewhere to live. I had enough about me to try and look at what I could do with my life moving forward. I had people that were genuinely interested in how I got on with my life. Very soon after kind of becoming professionalised, I noticed that not everybody had that. So what we decided to do was to take that massive black hole and fill it with practical, emotional, aspirational and other needs based on what the individuals were presenting with. So in 2014-15, our organisation worked with 791 people on 2,043 occasions, delivering 2,622 interventions. But what was really interesting is when we looked at the data from last year, there were 57 different areas of need that people presented with. So these 791 people had a huge range of needs that they wanted or wanted to be addressed or weren't sure how to go about addressing them. As we're a peer-led organisation, so we're not necessarily professionally trained, or we weren't at the start. We needed to ensure that we were competent and confident in ensuring that we met the full range of needs that individuals presented with. And when I say 57 different areas of need, they range from immigration issues to bereavement to mental health. And we've created our own kind of bespoke way of gathering data, not because it was written into our SLA, but because we genuinely wanted to know what we were doing. If we compare what we do to what's out there in terms of the system, as it were, Everything's very prescriptive within the system. You know, the targets are set up in certain ways to achieve certain outcomes, and I'm sure that the driver for that is in the right, coming from the right place. But what that does for me personally, it directs everyone involved in that system towards achieving these targets that don't necessarily achieve the individual need. And I think that's a fundamental part of what we need to change in terms of effectively supporting people in moving forward. It would be wonderful if things worked in synchronisation, if housing support worked in synchronisation with Department of Work and Pensions, worked in synchronisation with drug and alcohol treatment services. The world in which we work does not operate like that. But the organisation that I manage and that I love has the opportunity to be that binding glue that brings things together. That's culminated in things like supporting 132 people back into work in the last 4 years. Last year we made 840 educational interventions, 702 housing interventions. I mean, the list goes on and on. But if I reflect now on what happened in my life, being invited to Buckingham Palace, being awarded Chartered Manager of the Year, I think the true test for us is unearthing the potential within all of those people that are out there in need. I think they have the power to unlock change in others, change in themselves. And that has to be done obviously on an individual level to begin with. And then hopefully the more times that we do that as society, the more people will get better, the more people will achieve their potential. In this world in which we live, there's a great deal of social inequality. I think all of us have the opportunity to positively influence other people's lives. And I think we should take that responsibility very seriously. And until we do so, there will always be people out there who are looked down upon, who cause harm to themselves and society.